Hello, I'm Amy Cannon.
And I'm Amber Kelly.
And we're going to present for you our mid-range theory analysis on Michel's uncertainty and illness theory.
Born and raised in Boston, Massachusetts, Myrtle H. Mishel graduated from Boston University in 1961 with her bachelor's in arts degree. In 1966, she graduated from the University of California with her master's in psychiatric nursing. In 1976, she graduated from Claremont Graduate School with her Master's of Arts degree. And in 1980, she graduated again from Claremont Graduate School with her PhD. It was her personal experience of watching her father cope with colon cancer that led to her desire to examine the correlation between uncertainty and the psychological effects of uncertainty. She was a former psychiatric nurse serving in acute care and community settings. She worked as a nurse therapist with individuals in the heart transplant program at the University of Arizona Medical Center. She has enjoyed many prestigious faculty positions throughout the country. She continues to develop and test her theory of uncertainty and illness. Currently, she contributes to the education of future nurses as a distinguished faculty member at the University of North Carolina at Chapel Hill.
Originally drawn from psychology-based models, the theory was developed from information processing models and personality research. She credits Lazarus and Folkman's framework, applying this framework specifically to uncertainty, which gave it great meaning in the realm of nursing. She used both qualitative and quantitative findings, which ultimately led to the development of this theory. Original empirical studies focused either on the antecedents or the uncertainty as a secondary occurrence. Michel's research began to focus on uncertainty as the focus of the research. There were 4 academic journals used and the chapters of 2 books, one of which was a primary source. All of the primary sources were penned by Mishel as either the sole author or a contributing author. Theories of Uncertainty and Illness by Clayton and Mishel in Smith and Lair. Middle Range Theory for Nursing was the book chapter that was a primary source. And the journal articles included Patients with Chronic Hepatitis C Undergoing Watchful Waiting, Exploring Trajectories of Illness and Uncertainty and Fatigue. This came from Research in Nursing and Health, and it was by Bailey, Barroso, Murr, Sloan, Richmond, McHutchison, and Mishel. And also we used evaluation of a conceptual model based on Michel's theories of uncertainty and illness in a sample of Taiwanese parents of children with cancer, a cross-sectional questionnaire survey. This came from the International Journal of Nursing Studies. This was by Lynn and Mishel from 2010. We used an article that was just penned by her alone. It was called What Do We Know About Uncertainty and Illness? This was from the Japan Society of Nursing Research. She did this article for them, and it was very interesting. And also we used Test of a Conceptual Model of Uncertainty in Children and Adolescents with Cancer from Research in Nursing and Health. This was Stewart, Mishel, Lynn, Terhorst, and this was from 2010.
In discussing the conceptualizations of the nursing meta-paradigm, Mishel describes the person as a patient, family, or caregiver. The environment is directed at the environmental situation. Health is the current or perceived health status. And nursing is directed at how the nurse can help the patient develop proper coping mechanisms. Some major central concepts of uncertainty is included as uncertainty, cognitive schema, stimuli frame, symptom pattern, event familiarity, event congruence, structure providers, credible authority, social supports, and cognitive capacities.
We will be discussing these definitions later when we discuss the model. We also will talk about inference, illusion, adaptation, new view of life, and probabilistic thinking also as major central concepts. There were 4 major assumptions. The first 2 are psychology-based. The first one is uncertainty is a cognitive state. The second one is uncertainty is a neutral experience. And the second 2 are considered contested by Mishel herself and many others. The first one in this set is adaptation is a continuum of an individual's behavior, and that uncertainty is a linear, unidirectional relationship moving from uncertainty to adaptation. And basically this when they thought that you could not go back. You had to only move one direction. She revised her model, and through the chaos theory, this was a flaw, and she corrected it.
Mishel believes that uncertainty occurs when there is a lack of illness-related cues which are important to the individual for structure and predictability. Uncertainty can appear as many forms such as ambiguity or complexity. As certain concepts increase, uncertainty decreases, namely event familiarity, symptom pattern, and event congruence. Structure providers strengthen the stimuli frame, resulting in a decrease in uncertainty.
When appraised as dangerous, uncertainty prompts coping efforts in an attempt to reduce the uncertainty. If ineffective, the efforts can be aimed at the management of the emotional response and lead to severe emotional distress. But when viewed as an opportunity, the coping efforts are aimed at maintaining that uncertainty. So the goal here is to maintain the most positive coping mechanism as perceived by the individual. Without proper adaptation and coping mechanisms to uncertainty, the individual will experience an unstoppable mode of functioning.
And now I'm going to discuss the uncertainty and illness model. Mishel herself defines uncertainty as the inability to determine the meaning of illness-related events. Although there are many terms to comprehend when using Mishel's model to perceive uncertainty and illness, the concepts are actually quite simple. According to the model of perceived uncertainty and illness, uncertainty is influenced by social supports helping the individual to understand the meaning of current events. Adaptation is important to Mishel's theory and is derived from three major concepts: antecedents of uncertainty, appraisal of uncertainty, and coping in uncertainty.
The antecedents of uncertainty have both a direct and indirect inverse relationship with uncertainty. The concepts of structure providers, cognitive capacities, and stimuli frame are included in the antecedents of uncertainty. Under the concept of structure providers, the concepts of credible authority, the degree of confidence one has in their provider, social support, and education are all considered. Structure providers, along with cognitive capacities, the information processing abilities of a person, affect this stimuli.
Stimuli frame refers to the appraisal of uncertainty and consists of the concepts of inference and illusions, which will be discussed later. Included under stimuli frame are the concepts of symptom pattern, event familiarity, and event congruence. Symptom pattern refers to the consistency in which the symptoms occur. Event familiarity refers to the recognized cues contained within an event. Event congruency refers to the consistency between both the expected and experienced events. All of these antecedents directly affect the uncertainty experienced by the individual.
According to Mishel in 2006, the inferences refer to one's interpretation of uncertainty using recalled and related experiences. Illusions are beliefs created out of uncertainty. Inferences and illusions affect adaptation to uncertainty by deciding whether the uncertainty will be considered a positive or a negative event.
Coping with uncertainty involves the possibility of two pathways depending on the patient's cognitive schema or interpretation of the illness. If considered a danger, uncertainty includes a direct action, vigilance, and information seeking. In this pathway, mobilizing coping strategies and effective control strategies lead to the adaptation. If, however, uncertainty is considered an opportunity, a buffering coping strategy is elicited in order to maintain the uncertainty, thus leading to adaptation.
When uncertainty shifts from a perceived danger to a perceived opportunity, the term new view of life is used. According to Bailey and Stewart in 2010, this occurs often when the patient realizes that life can change. The concepts of system pattern and event familiarity are important to this concept. Next, we'll be discussing the logical forms and flaws.
Neither is purely deductive nor inductive in nature. The theory was developed from gathering quantitative and qualitative data from questions about clinical problems and applying theoretical models from other disciplines.
Since the theory's original publication in 1988, researchers, including Mishel, have tested and mainly confirmed the relationship between these key concepts in the model as it relates to illness. Mishel found and corrected flaws within the original model after research indicated that uncertainty was not a linear application, but that it in fact changed over time. Empirical evidence generated from qualitative studies suggests that a person's response to uncertainty can change over time. The uncertainty in illness theory is a bidirectional process and demonstrates how theory can both inform and be shaped by research.
The theory has continued to generate knowledge on the concept of uncertainty. Mishel and colleagues confirmed the major components of the model. They continue to test the psychoeducational nursing interventions derived from the theory. The theory and scales have also been used in other disciplines and has been translated in 12 different languages and are used around the world.
Speaking about nursing education, specifically the graduate programs, this framework has been used for thesis and dissertations, critique of middle-range theories, and concept analysis. And as far as doctoral programs go, it demonstrates how theories guide nursing practice.
For the advanced nursing practice, the theory has been used in acute illness. Stewart et al. Concluded that there is a correlation between a child's uncertainty and their level of psychological distress. Hilton used the theory to demonstrate how patients who are recovering from a recent cardiac event, being uncertain of the interpretation of physical symptoms, may limit physical activity, which is essential to the healing process. It has also been used in chronic illness and in cancer. Ryder applied the uncertainty in illness theory to endostomal therapy nursing. Stewart, Mishel, Lynn, and Tersole used the uncertainty in illness theory as a framework for their study in children and adolescents with cancer.
The implications of the theory include the following. It's applicable to many different aspects of nursing, including advanced practice. It is the responsibility of the advanced practice nurse to care for the whole patient, not just one major symptom. And the psychological components of uncertainty have been shown throughout research of Mishel and others to have a profound impact on the overall health of the individual and their loved ones. By understanding and utilizing the model, the advanced practice nurse can better anticipate the care needed by the individual experiencing the uncertainty. This can be accomplished through the use of a personal scenario for the illness in which aspects of the disease process are explored, such as what caused the illness, the progression of the illness could be discussed, and the application and the aspects of patient's recovery. The ability of the advanced practice nurse to address the uncertainty faced by an individual gives them a sense of trust in their caregiver, as seen in the credible authority concept.
The clinical scenario is that a 42-year-old woman has just been given the diagnosis of breast cancer. She is a widowed parent of 2 children, one girl 10 years old and one girl who's 13 years old. She has just learned that she must endure chemotherapy and fluid replacement, which will occur on 2 days consecutively each week for an undetermined amount of time. She's experiencing uncertainty related to the possibility of the disease outcomes, ability to care for herself and her children. The APN develops a plan of care based upon the patient's uncertainty using the MUISA.
First, the patient's level of uncertainty must be evaluated. Considered here are the concepts of structure providers and cognitive capacities. Both cognitive capacities, such as her ability to process this information, and structure providers, the available resources that the patient has to draw on, are necessary to assess. Included in the structure providers are the level of confidence that the patient has in the advanced practice nurse or the credible authority, also the social supports available, and the patient's level of education.
Second, specific components of the stimuli that the person identifies are considered. This is known as the stimuli frame. Included here are symptom patterns which she has not experienced yet, as she has not begun her treatment, but that she has been anticipating. Event familiarity and congruence also falls under the stimuli frame. Here she reveals that while she has never experienced cancer, she has witnessed the effects when her maternal aunt had it. The patient states that I know what to expect with the treatment, however, I do not know if I'm as strong as she was. All of these things combined will determine the level of uncertainties experienced by the patient.
Next, the appraisal phase of the model is considered. This includes the concepts of inference and illusion and their effects on adaptation. An example of this is when the patient says, "I know that people make it through this every day, but they have a lot more help than I do. There is no way I can care for myself and my kids while fighting this disease." It is at this stage that the uncertainty is perceived to be either a danger or an opportunity.
Finally, the adaptation phase is considered. Here, coping strategies are implemented. The APN will address uncertainties and assist the patient in effective coping skills. She can help by educating the patient of disease processes, treatment side effects, referring the patient to support groups for herself and family. All of these things will assist the patient to accept the uncertainty as a normal part of the disease process that can be effectively managed.
In summary, we would like to say that uncertainty is experienced by an individual with an illness, and the degree of uncertainty correlates with the amount of psychological distress.
And as the APRN's role, it is important to evaluate the degree of uncertainty, assess the effects of uncertainty and psychological distress, educate the patient, and then reassess the degree of uncertainty.
These are our references that we used, and we thank you for joining us. Bye.